Now, if you guys look on here, it says PA or AP for certain ones. The UGI only has the PA. Because for the most part, you want that stomach as close as possible to the receptors so you don't get super magnification of the stomach. Sometimes it can get distended with like gas, or if they have a foreign object in there, it's better to get it closer than further. So it says 1 to 2 inches above the lower rib margin, or level 1 to 2 perpendicular. It's basically the exact same shots we just did, except further to the left. So whereas the esophagram, you were slightly to the left, here we're going to be well to the left. So find this, come down about a hand. What you want to do is the spine becomes one border of your image, the lateral skin margin becomes the other edge of your image. You can even open up a little bit just because you want to get that peritoneal sac as well. If they do have a puncture or they have a bleed somewhere, it can fill up that sac. So you guys might have seen it if you've been in like the emergency room. Fluid starts to accumulate on like one side of the abdomen. That's almost always a bad sign. If it's equal on both sides, it's just a fluid issue. But if you see one side filling, you're worried about a puncture or leak somewhere, right? Okay, so stomach's right here. Why do I want to keep the spine included in my image? Why don't I just clip it out?
The reference point?
Reference point's nice for me visually. What else? The stomach has to go somewhere, right? Where does it go? What comes after the stomach? Duodenum. Which direction does duodenum go?
Medial.
Medial, right, to the right. So, food's gonna come down in the stomach and then it's gonna curve back away. I wanna watch that duodenum come right here because my duodenal bulb is gonna be here and my duodenum here. So especially if I was like doing an ERCP or something, I'm gonna have to be in that ampulla vader anyway. That's that exact area. Yep.
And you keep that same collimation of 17?
Yep. Better to give the doctor more information, especially if you're doing like a scout film or something, right? The other thing to consider is body habitus. So for the comp, we're just going to assume everyone's sthenic, meaning normal, just it makes it easier for us to grade you guys. But if I have a patient who's hypersthenic, meaning really big, that stomach is going to come high and it's going to turn more this way. By going all the way to the spine, their stomach's not pushing to the right, completely to the right side unless they have situs invertus. So it gets you a little leeway to deal with their body habitus as well. The other way is also crazy when they're hyposthenic and the stomach kind of makes a U and it dips down really low, you'll still be good because you went down low enough to fit all of that in there. So a little bit of extra intestine never hurt anybody in the picture, right? So that's going to be your first shot. The oblique is literally the exact same oblique we just did for the esophagus. Bend the right knee, or bend the left knee, bend the left elbow, come in here, half of the half, but you shoot right there. It's the exact same shot, right? There you go. There's your UGI. Go back flat for me for a minute. But we have another shot here. If you look at the sheet, we have an axial. So for the esophagus, it was only 3 shots. For the UGI, it's going to be 4 shots. We do a PA axial and it says sthenic at level of L2, higher for hypersthenic. Because your hypersthenic patients, it gets pushed up and it gets turned, right? The reason that we're going to do the axial is because we need to see up into the fundus and into the cardiac sphincter, especially on patients with like GERD or gastroesophageal reflux. You want to see, is the issue the acid in the stomach, or is the issue the sphincter is not doing its job properly? So it says on here 35 to 45 degrees. Which direction do you think?
Cephalic.
Cephalic, because I'm going to look up through there. There's an axial for the barium enema, it goes the opposite direction. You go caudad because you're looking through the sigmoid rectum. So you flip them back and forth, right? Now 35 to 45. For my sthenic patient, which one do you think I'm going to do?
45.
Why would it be 45?
No, it'd be 35, 45 for the hypersthenic.
Correct. The more hypersthenic, the more everything's pushed up, the greater you have to angle to make up for the pushing, right? So 35 would be for your sthenic patient. So how much do I need to drop?
7 inches.
Which would be 30.
3.
Or 32. You got math like me.
Always gotta account for the bucky too, though.
Okay, but now I got a match, right? So I'll pull down. This is where it's nice to leave yourself that little extra space on your bucky in case you need to come up a little bit to match it. Right? The centering is going to be exactly the same, but now that I shifted, so I need to go back. So what I used to do is I would take my marker and I would put my marker where I was happy with the PA position. That way I can just slide back to that point. Kind of like we did, what was the other one we did that for? The femur or something like that, right?
Yeah.
We were using that trick. Yeah.
This one.
Same idea here is that you put the marker there and you just cut through your marker again. That way you're not like searching for your position all over again, right? So right there. Right there. Good. Shoot there. Same thing where I want to have the spine on one side, the lateral skin margin on the other, and I shoot up to see the fundus and cardiac sphincter, right? Those are going to be the 4 shots for the UGI. Pretty straightforward, right? They're not that different from the esophagram. This is the tricky one. And this is the one where everybody kept failing their comp last time I taught this. Why do you guys think?
They forgot to detent?
They forgot to detent it to the angle. They weren't moving their board after, right? So make sure you're re-detenting every single time because they were doing close enough to the angle, but they weren't detenting the back. You can lay on your back for me now. Okay, so we're gonna move on to the small bowel. Now I can slide my bucky down because I'm gonna be working in here, right? For the small bowel, I want to use my full 35 and 43. I'm going to use my whole board. Sometimes people my size, Alan, Ryan, you might have to do 2. You might even have to do quads, like we've worked on large football players where we had to shoot every part to get them. So what was like a 5-shot exam before becomes like a 10-shot exam or something like that, right? So for this one, I have an initial and I have a delay. So if you look at the sheet, it only has the one view. It just says AP or PA. Should we do AP or PA?
Small bowel. No, PA. It's closer to the.
Yeah, PA, because the intestines get closer. Absolutely, we're not going to do it. Now, this is where, again, practicality versus better image comes into play. They're going to have to be here for a minimum of an hour. Perhaps longer. I've done days with these exams before, right? So, because of that, I'm not going to have him on his stomach because then we're flipping onto your stomach all day. You're putting a lot of compression on an area that's already painful or distended. So, even though the PA might be the better shot, and Merrill's would say, yeah, you should absolutely do these PA, the practicality says we do them mostly AP, right? So, we're going to do it AP. And then it says here, initial at L2, delayed at the iliac crest. Initial what?
Initial
shot, initial drink. So you'll do a scout film first, and you'll do a high scout. So instead of just like a scout KUV low, you go a little bit higher so that you can see the stomach, because that's where basically our exam starts, right? So I want to go to the level of L2. It's the exact same place we just shot, right? It's the exact same as the UGI. You get the stomach, you fit everything in there, right? The other way you can do it is you can find the crest and go up 2 inches. It's up to you which way you want to get there, as long as you get to that spot, right? Then you go straight down the mid-sagittal plane, so we can fit everything side to side. Your patient takes a drink, and then you're going to put 0-minute film, right? This is your initial shot, and it's going to be high. When you go to do your delayed shot, you're going to slide down to the iliac crest. The real trick to this isn't can you go up and down. I don't really care about that. You're not impressing me that you know to go 2 inches lower. Instead, when do you go down? What is considered delayed? Throw something out there.
1 hour.
Okay, so 30 minutes. What about a patient who has really slow transit? They have bad gut motility. I've had patients where it just sits in that stomach the whole hour and it never slides down. So instead, this is where I'm saying you have to use your brain a little bit because you can't just like assume at 30 minutes it's going to be there, right? So you take your initial, you go, okay, it's mostly in the stomach and I'm starting to see it trickle into the duodenum. I'm not going to go down for my 15 minute. 15, I'm going to stay high. I shoot again and I go, okay, now I have some good transit. It's in the jejunum. I'm starting to see it hit the ilium. Once I hit the ilium, that's when I go to my delay. Because eventually I want to end up at the iliocecal. Is that on the right or left of the body?
To the right, yeah.
It's on the right, so it's down here, right? And it's low, it's really low. Because then it's going to come back around in the large intestine. So when I see it going from jejunum to ileum, that's when I'm gonna make my delay. Yep,
So how often are you taking shots to see how it's moving?
15, 30, 45 hour. Some of your facilities do 0, 30, 60. So if I haven't taken a shot since my initial, I stay at my initial. Then I let the shots dictate to me when I go to my delay. This can be like a 6-hour procedure. I might not go to delay until hour 3, right? It's possible. It depends. It's all dependent upon the patient, right? Sometimes, remember we talked in rad protection about GI syndrome and how it sloughs off the lining of the intestine? Some people, transit's immediate. They don't have that peristalsis. It's not, things just flow right through them, right? Your patients who have persistent diarrhea, and sometimes we're doing this to figure out why, it just runs right through them. Patients have bowel resections where they cut out some of the intestine, their transit time is going to be much faster as well. Then you're going to get the other ones who are dehydrated, they have a stricture somewhere, or a volvulus, or a twist, or something, right, a blockage, and it trickles, and it takes forever to move. You have to you can't just be dogmatic, you gotta go with what the presentation is. Because the other thing that can happen, I see it in the stomach on my initial. I take my 30 minutes, and none of the bowel is filled. So I look back at the stomach, and I go, it's not even in the stomach anymore. Where's my contrast?
It's leaked out into the kidney.
Hopefully not the kidneys. Could be, like it could be leaking into the peritoneum. That'd be true, but I would see it hopefully, right? Like leaking out. I'm more concerned it's refluxing and he's swallowing it, which means it's going down his trachea, or he's vomiting and not telling me, which is also possible. Because I'm giving him 2 big cups of this. Most of your small bowels are 2 of these, or if you're using gastrographin, it's 2 cups mixed with water. That's a lot of fluid to go missing. It has to have gone somewhere, right? This is why if you just jump to your delay at 30, you might miss the fact that they refluxed a bunch of it back up out of their stomach, right? So you kind of have to play it by ear. Those are the only 2 shots we're going to do for the small bowel. We're going to do the initial and the delayed, but how many shots do we do for comms? 3. So where do you think that other shot's coming from?
The scouts.
So you're either going to get the axial UGI or you're going to get the axial PE. Basically, you're going to get the hardest shot from one of the other 2 because it's the easiest series to do of all the group of them. Does that make sense?
Yeah.
Seems somewhat fair, right? Okay. So that'll be the comp for this one. You'll check that. Any questions about those exams?
Wait, so this is for the small bowel series?
Small bowel series. You do initial, and I'll tell you, now show me your delay shot, and then I'll say, now show me either the axial UGI or the axial barium enema.
Is it common in hospitals to do like 15-minute?
You're supposed to do 15 minutes. Do they do it is another question.
I think my site does like
0, 30,
One-
60.
no, we do like 1 hour,
Yeah, same.
like 1, 2, 4,
Hours?
8.
Oh, you're doing inpatients.
Yeah.
That's different. We're talking like you bring your outpatient in, they're
Okay.
on your table. They should, even in inpatients, they should be on your table for the first hour, then you send them upstairs for the additional hours.
Oh, you go up.
I know, but you don't want to do, I'm saying that's not good practice.
I see.
The reason that's not good practice, if they're going to have a reaction to the contrast, I want them to have it with me where I can watch them do it. Because if I go upstairs and give it to them and walk away and no nurse rounds on them for like 30 minutes, they could already have died and aspirated in the room. So we do, in our facility, we give contrast in our visual range. Then once we see, okay, they're not having a reaction, okay, we'll come up in 3 hours and do the next shot.
There was a patient who like threw up the contrast twice, and we're like, let's do this down another day. And we just left.
Problematic, is my point. Like I've told you guys many times before, what happens in the field is not what should happen in the field. You should not be giving contrast and taking your eyes off that patient until at least an hour. For this.
It doesn't happen in field, guys.
I know. But you need to keep an eye on it, especially if you're gonna do IV contrast. You better be in the room when you're doing IV contrast, otherwise we have massive issues. That's a patient safety violation right away. With this stuff, your GI system, it takes time, it's not as sensitive to allergies. You're probably not gonna kill someone with the contrast when it's PO. You're gonna kill them because you're gonna drop them. And we're gonna talk about that in a second. But the reality is, I still wanna see it. I wanna watch them and go, you're breathing, you're okay? I wanna see that visually before I let them go upstairs or do whatever. Now, we don't leave our patients like this the whole time. Who's done a small bowel series? What do you guys do with your patient?
Let them walk.
Walk them around and stuff, right? So, At the bare minimum, what you should do is you should turn them onto their side. So you're gonna do your images flat, but when you actually like, okay, we have 15 minutes where we're gonna sit around, you wanna turn your patient and you wanna turn them to their right side. Put pillows, wedges, something underneath them, right? To hold them up. Not fully lateral, just like this, right? You can go back flat. Matter of fact, Mike, you can hop off the table. Let me get you out of that. Oh, that's Jesse up here, he was being punished. So, you want to turn them onto their right side because your stomach empties to the right. It comes, your stomach isn't this perfect like globe. It actually goes posterior, superior, then there's like a little hill in it, and it dumps down to the pyloric region and curves away to the right into the duodenum. So, by turning the patient slightly on their right, you do two things for yourself. One, you let gravity help pull the contrast down, bless you, so the exam goes quicker. Two, if they're gonna reflux, the chances of them refluxing and aspirating are much lower when the patient's on the right side than the left. That's why when you eat a big meal, if you're gonna lay down after, lay on your right, not on your left. Your reflux more, your GERD will be worse. Now, when you get further on into the case and it's down in the intestines, you might hear people say, no, we always still stay on the right side. You're not doing much at that point. It's already clear of the stomach and intestines are pretty tightly bound. At that point, it might actually be more beneficial to kind of turn back and forth a little bit. So that's what you do with a patient who's not walkie-talkie, who's inpatient, who's malnourished, right? But what we used to do is, and this is when I was a student, we had to walk them up and down the hallways. And they're sitting there going, my daughter wants to be a doctor, and I had cancer, and you're like, well, yeah, that's nice. And you just walk around, you have to be stuck with them for a minimum of an hour, right? And the doc's like, we're going 3 hours. And you're like, I really have so many stories I can listen to. We used to do that. Then our department policy had to change because the student was walking them and left them, and they went to the cafeteria and ate. And that ruined the whole procedure. Now the patient has food in there, and they're supposed to be MPO. So what we did instead is we used to take a chair, we put the chair in the room. So at least by sitting upright, there's still some gravity and still helping you. But ideally, if your patient can walk around, it helps this exam go a lot quicker. You need to be careful about that. You're going to be dealing with elderly people who haven't had their first meal, are discontinuing medications, might already be dehydrated. So what I'm saying is, you're not going to kill them with the contrast. What you're going to do is dehydrate them further. They're going to get woozy and they're going to go down. I told the other group, there's this weird relationship you form with your patient when you do fluoroscopy where you're telling them, hi, my name's Mark, I'm with the X-ray department, I'm going to be taking good care of you today, okay? I'll be with you the whole procedure. Now, okay, this is my person. I want to do everything possible to make me feel better. This is the person who's going to make me feel better, right? They don't want to disappoint you. And you say things to them like, okay, it's very important that you swallow all of this, or that you don't throw this up, or that you don't pee, or that you don't, you know what I mean? So when they do it, they feel like they let you down, so they don't want to tell you. So I've had patients where we're doing like an IVU, I run the contrast, and I'm like, where is my contrast? Like I went to take my shot, and I'm like, the bladder should be full. I'm like, ma'am, did you urinate? Yeah, I didn't want to tell you. I'm like, no, if you told me, I could have took the picture and we could have seen it come out. Like that would have been useful information. Or they throw up, but they're embarrassed, or they feel like they let you down, so they do it off to the side, or they re-swallow it, or you run into these situations and then their aspiration chants go up because now there's stomach acid mixed in with your contrast. There is this tightrope you have to walk of friendly and on their side, but also you have to be careful of what you tell them. So the example we were giving in the other group was when I was in CT, we would tell patients, right? Oh, by the way, it's gonna feel like you have to pee. When someone tells you, hey, you might pee, what does your brain think? I gotta pee. So sometimes by telling someone, hey, if you vomit, you need to let me know, I'm gonna vomit, and now they're in their head, and so there's no right answer to this. I'm just saying it's something you have to consider. It's like an additional consideration when we do these exams, right? The BE, I'm not gonna go over the positions today because we're gonna do an entire BE day next week. We're gonna use the dummy. The dummy has anatomical holes. We're gonna practice tipping, and I'll show you how to set up I don't know where it went. We have an IV pole, it's over there, an IV pole. We're gonna hang bags and all that. So I'll have all that set up probably next Friday. What I wanna mention now And it's because the first time I taught this class, we had a bunch of jokers, and you guys have met some of the people from that group. There's a giant window there. If you're doing stupid, inappropriate things and screwing around during the exam, I'm throwing you out of the lab. Okay? I can't have any tolerance for it. So we have to have like a certain level of maturity when we're practicing the BE exams on each other. Don't be throwing people under the bus, Michael. Wow, what a rat. This is why you don't land yourself. So, generally speaking, just the level of maturity when we do it has to be a little higher, okay? I don't want to have to deal with that issue again. Luckily, I was new enough that they're like, he's too dumb to know that they shouldn't be doing that. Right? Okay, questions about any of that stuff? Questions about, yeah?
The word doesn't change at all, like even for the small vowel series, like it stays portrait the whole time.
So that's a good question. If I'm shooting Lynn, yeah, everything's going to be portrait. If you're shooting me, you're going to have to do uppers and lowers. So you might go landscape high, landscape low. For the esophagus, you should always be portrait. It's a thin tube. It's like doing the spine, basically. Even the upper GI, you'd be hard pressed to find someone whose stomach is so big it needs to go landscape. But if they're really hyperstenic and it's very transverse, you'll learn on the scout. Okay, maybe I should turn it. Most people are flying portrait. The other ones, it's probably body habitus.
So is portrait or?
Let's do portrait for the esophagus, portrait for the UGI. Yeah, just say portrait. It's fine. It's gonna work better anyway. Even for the large vowel, like it's hard to fit all of that into a frame, but if you turn it to